All right. Thanks to everyone for coming on site. We always appreciate that. And to everyone joining online. My name is Ben Smith, for those of you who don't know me, one of the directors at CORE. And I have the pleasure of introducing Dr. Maria Velez, who's a reproductive epidemiologist and physician in the Department of OBGYN, also a scientist at the RI. So she's going to hopefully teach us something interesting about accessing administrative health data from Ontario and maybe elsewhere, but and see how we can maybe try to do similar things here in Quebec one day. So she comes to us recently by way of Queen's University. Before that, she did training here at the University of Montreal. So I'll pass the mic over to her.
Thank you. Thank you, Ben, for the introduction, and thank you, everybody, for being here and those online. So I'm going to present today my work for the past 10 years that I did while at Queen's University and also as an ICES scientist on the use of administrative data for the study of reproductive and pregnancy outcomes. Perfect. So I don't have any conflicts of interest to disclose. The objectives for today are to learn how population-based data can be used to investigate reproductive and perinatal outcomes. Also to know what are the methodological challenges about the infertility itself versus the fertility treatments, and how can we apply modern epidemiological methods to study these outcomes. So infertility in Canada and around the world, we say about 1 in 6 couples or individuals experience infertility. This is data from the Canadian Community Health Survey that says, according to the definition that we use, infertility is about 12 to 16% prevalence. This is data from the Canadian Assisted Reproductive Technology Registry. So all the IVF clinics in Canada will submit information about the IVF cycles that they have, how many collections they had, how many were successful pregnancies, and if there was a live birth. So if you can see, in 2001, we had about 8,000 cycles, and that has increased substantially to over 35,000 cycles in 2019. Then we had COVID, and it decreased a little bit, but now we are up to around 30,000 cycles of IVF treatment in Canada. In 2016, when I started at Queen's, we got this CIHR team grant, clinician investigator teams in obstetrics and gynecology and maternal fetal medicine. And one of the objectives was to study outcomes in pregnancies conceived through the use of assisted reproductive technology. So with my colleagues, we wanted to know the role of fertility treatments on pregnancy outcomes. The first thing we did with some of my students was to do some systematic reviews to see what could we do different or what research questions needed to be answered. We know that multiple pregnancies are more common in fertility treatments, but what about singleton pregnancies? Do they experience also adverse outcomes? So in this review, we included only singleton pregnancies. Flavia was a postdoc working with me, and Gillian, a health sciences student who is now doing medical school. And with them, we did a systematic review where we identified that fresh embryo transfer, so that's when the patient has a collection and then the embryo is the oocyte is gonna be fertilized, then that embryo is gonna be transferred in a fresh cycle, and we compare those with frozen cycles. So in fresh cycles, we see that those couples had a higher odds of preterm birth, low birth weight, small for gestational age, and those who had a frozen embryo transfer had also a higher odds of large for gestational age babies. Then we wanted to know the role of assisted reproductive technologies with hypertensive disorders of pregnancy. Tiffany, also a medical student working in research with me, now doing residency in obstetrics and gynecology, did this huge systematic review where we identified that frozen, like fresh embryo transfer was associated with 1.43 odds ratio, significantly association, and a frozen embryo transfer was associated with an odds ratio of 1.74 with significant confidence intervals. Then Nakisha wanted to study C-section in pregnancies conceived by assisted reproductive technologies. We know if these patients have maybe more complications during pregnancy, the rate of C-section is going to be higher. But and that's what we saw here, emergent C-section, the odds ratio was 1.38. But we also identified that elective cesarean section was very high in patients with assisted reproductive technology at odds ratio of 1.91. But what is the role of underlying infertility? And this is where I want to introduce the concept of confounding by indication. Confounding by indication will occur when a patient factor, such the decision to receive a specific treatment, will have an effect on the results that we are going to have. So the two groups are going to be unbalanced. For example, in assisted reproductive context, individuals who are going to have IVF are probably older because they have been trying to conceive for a longer time. Some have risk factors, for example, obesity, which is associated with a delay to conceive, or polycystic ovary syndrome. And those are probably those who are going to have more severe forms of infertility, because if you have a less severe form of infertility, you might conceive without any treatment, or you might conceive with ovulation induction. You might not need IVF. So we know that age, comorbidity, and those latency factors may affect obstetrical outcomes through different pathways independent of the fertility treatment. So how can we minimize confounding by indication? We can use an active comparison group, for example, women who had infertility but didn't have assisted reproductive technology. We could also restrict or stratify by the reason of infertility. We need to, as always, do an adequate adjustment by covariates, use causal inference methods to minimize confounding. We should avoid conditioning on mediated errors. For example, multiple pregnancy, which are more common in patients with assisted reproductive technology, or preterm birth or C-section. And when we want to know what are the mechanisms causes, we could use mediation analysis to try to determine the effect that is directly by the fertility treatment or the underlying infertility diagnosis. And I'm going to show you some examples of that. So this is ICS. Now we call it ICS. This is the map of Ontario here, and ICS believes in the power of data to improve health. ICS is an independent health research analytic institute, and we do population-based health research with the goal of make a difference. About 300 scientists and 300 staff. The mission of ICS is to translate data into trusted evidence that make policy and healthcare better for healthier population. We want to improve health and healthcare for everyone through this nice and research. So these are the values of ICS, which I think is good to mention that at ICS we strive for excellence, integrity, work that is relevant, we collaborate and respectful to each other. And this is a collaborative network across Ontario. So ICS started as ICS Central in Toronto. Then the second one was at Queen's University, where I was, and then it has expanded, and there are now 7 nodes of ICS across Ontario. This is the research capacity at ICS, so 121 data holdings. These are the sharing agreements during the fiscal year 2023-2024. Almost 400 graduate students using data for their projects, and 632 graduate medical postgraduate training that are mentored by ICS scientists. There are different research programs, cancer, cardiovascular. My program is the life stage. These are the number of investigators and publications in that fiscal year. So at ICS, we use the identified data. So they will produce like an algorithm to produce an ICS key number, IKN, and through that we are able to link like all the databases to our research. So these are examples of the databases. We have the census, immigrants, so we have access to the IC, like immigrant information, First Nation, Métis. We also have information about the Ontario OHIP billing codes. We have ICD-10 codes. We have hospital data. And this is for health service registry data. So we have for diabetes, hypertension, respiratory condition, asthma, COPD. There are also this type of data. I haven't used them in particularly, but interested in the future to study, for example, school readiness in children born after assisted conception. There are other project-specific research data. These are projects that were outside of ICS, and then they can be brought to ICS and be linked to all the other administrative databases. I use mainly the born database, which is a database that will register all the births, hospital births, which is more than 99% of births in Ontario. And we have information about pregnancy, antenatal care, delivery, pregnancy complications, mode of conception. So if they were an assisted conception or if they required fertility treatment. So that's important for the type of work that I do. So with Emily, who is now a resident at Queen's, we wanted to study C-section in women with infertility using a population-based approach. We know that 1 in 4 births in Canada are by C-section, and C-section is the most common inpatient surgery. We wanted to assess the association between mode of conception and C-section rates across the Robson groups. But yeah, so what are the Robson groups? The WHO proposed this classification to try to understand why we are doing C-section. Is there an indication or is an elective C-section? So they have these 10 groups according to parity, previous C-section, gestational age, onset of labor, is it a cephalic or bridge presentation, is it a singleton pregnancy or a multiple pregnancy. So using ICS data, born data from 2006 to 2014, we identified our exposure categories. And this is an assisted conception, so spontaneous conception or natural conception are other names, but we prefer the name unassisted conception. The other treatment group is those who had ovulation induction or intrauterine insemination. And the last group are those who had in vitro fertilization or intracytoplasmic sperm injection. This is when we inject the sperm directly into the egg. But then we wanted to identify those who had infertility and didn't have fertility treatment. So through the ICD-9-628 code, which is infertility diagnosis, we identified those women who had a consultation for infertility but did not require fertility treatment for that pregnancy. And that's the group that we call infertility without fertility treatment. Others will call it subfertility. And this, as you can see, this is the unassisted conception group. They are younger compared to the fertility, like treatments group or infertility without fertility treatment groups. Also, those who had infertility treatment were in the highest income quantiles. Polycystic ovary syndrome, fibroids, endometriosis were more common in patients who had fertility treatments, and multifetal pregnancy here was more common in those who had ovulation induction and IUI, and those who had IVF had 25%. Those are high rates of multifetal pregnancy. So then here you can see that the number of C-section and the rate in the first column, it increases with the invasiveness of treatment, as high as 50% in those who had IVF treatment. And then here you will see the relative risk for C-section, 1.39 if you had IVF. So then we wanted to know what Robson, in what Robson group they were, and those who had spontaneous conception or subfertility, the most common reason for C-section was because they were multiparous and they had a prior C-section. The subfertility group was followed by what we think is elective C-section. So they were nulliparous. They had a pregnancy in singleton position, and they did not start in spontaneous labor. This was followed by non-invasive IT group. The non-invasive IT group had also C-section as indication for multiple pregnancy, and the invasive IT or the IVF group, the most common reason for C-section in that group was multifetal pregnancy, followed by this group with no spontaneous labor. So we concluded in that study that the rate of C-section in Ontario is highest in women requiring fertility treatment, and these rates will increase with the degree of invasiveness of treatment. Multiple pregnancy continue to contribute an important reason for C-section in this population, and we need to continue our efforts to decrease multiple pregnancy in patients with infertility. We are not able, unfortunately, through these databases to study maternal satisfaction or what are the local available resources that can also contribute to the indication of C-section. Then we wanted to study preterm birth in patients who had fertility treatment, and not only preterm birth, but also if preterm birth was spontaneous or provider initiated. Pearl was a master student working with us, so we know that preterm is defined by the birth below 37 weeks gestation, and it's about 5 to 12% prevalence in the population. It has been categorized in spontaneous or provider initiated. Fertility treatments are associated with preterm birth, but we don't know if it's the effect of treatment or the underlying infertility. We also don't have information about spontaneous or provider initiated. Again, using ICS data, we wanted to study the association between mode of conception and preterm birth, and if it was a spontaneous or provider initiated. We used the same cohort as in the prior study, births from 2006 to 2014. The categories of exposure were unassisted conception, ovulation induction, IUI, or IVF or ICSI, and we identified women with infertility without fertility treatment. The main outcome was preterm birth less than 37 weeks, and a secondary outcome was less than 34 weeks. We also categorized them as spontaneous or provider initiated. We used modified Poisson regression to generate risk ratios, and adjusting for the categories. Pearl also used propensity score to make the population similar. We had over 900,000 births. These are the exclusion criteria. And we were able to identify almost 68,000 women who had an infertility diagnosis without fertility treatment, 9,000 with ovulation induction IUI, and 8,000 with in vitro fertilization, or ICSI. So patients with infertility, with or without treatment, they were more likely to be older, nulliparous, obese, and more likely to have a history of chronic diabetes. Chronic hypertension was also more common in patients with fertility treatments. In this table, in the first row, you will see preterm birth less than 37 overall. And as you can see, for an assisted conception, the rate of preterm birth was 6%, while it was almost 11% in the group of IVF and ICSI. When we categorize it by spontaneous or provider-initiated, we see the same trend. So 4.39% for an assisted conception was spontaneous preterm birth, while it was 6.5% for the IVF ICSI group. Similar trend was seen in the provider-initiated preterm birth. As you can see, the relative risks are also significant for the three groups: infertility without fertility treatment, ovulation induction IUI, or IVF. We saw similar findings for the less than 34 weeks, where patients with infertility and fertility treatment had higher rates and relative risks for spontaneous and provider-initiated preterm birth. So the conclusion of this paper is that this population was only single-term pregnancies. We excluded the multiples. And even in single-term pregnancies, we saw that infertility without fertility treatment, ovulation induction IUI, and IVF and ICSI were associated with spontaneous and provider preterm birth. So we are calling for future studies to know how can we decrease those risks. But what is the role of underlying infertility diagnosis? So among common causes for infertility are polycystic ovary syndrome, endometriosis, male factor infertility. In this study, we identified women with endometriosis. And we wanted to know if the mode of conception in this population was associated with adverse pregnancy outcomes. Endometriosis is a common condition. It affects about 11% of women of reproductive age, and as high as 60% of patients with endometriosis will have infertility. There is some emerging evidence that suggesting that endometriosis may be associated with adverse pregnancy outcomes, but we don't know if it's because many of them will require fertility treatment. Could that be the reason, or is the endometriosis itself? So endometriosis, for those who are not familiar, is the endometrial-like tissue that is outside of the lining of the uterus, of the endometrium. So these patients have endometrial-like tissue in the fallopian tubes or in the peritoneal cavity or in the ovaries. And all this can have cause an inflammatory condition that can be associated with infertility through blocking the fallopian tubes or the activation of oxidative stress and inflammatory pathways can itself cause infertility. These patients have also decreased ovarian reserve, which might be secondary to surgery because they can have ovarian cysts that are called endometriomas and can have surgery for that, and that can decrease the ovarian reserve. But there is also some evidence showing that maybe the endometriosis itself can decrease the ovarian reserve. So we wanted to know the pregnancy outcomes in patients with endometriosis. We used some ICS data. We identified deliveries to born from 2006 to 2014. We excluded multiple pregnancy again, and the inclusion was age 15 to 50. We wanted them to have at least 5 years of OHIP, like the Ontario Health Insurance Program eligibility, because we needed to identify if they had endometriosis before. So if someone had arrived just 1 year before the pregnancy, and during that year she didn't consult with endometriosis, we would have missed that. So we needed them to have at least 5 years of OHIP eligibility. The exposure was a medical or surgical diagnosis of endometriosis using the data discharge abstract database, the same-day surgery databases, and the Ontario Health Insurance Program databases that we have at ICS. Medical diagnosis was identified using 2 medical billing entries in the OHIP database with the ICD-9 code for endometriosis, or if they had an hospital admission and surgery with this, without surgery with these 2 codes. Surgical diagnosis was a hospital surgery with using the ICD-9 and ICD-10 for endometriosis. So we look back up to 10 years prior to pregnancy to identify endometriosis diagnosis. These were all the outcomes, which is quite a lot, that we studied, and we used modified Poisson regression and with rows to variance and GE component, because some patients might have had more than 1 pregnancy during the study period. We adjusted for age, income, and history of fibroids, because we identified patients with endometriosis had a higher rate of fibroids. Mode of conception, as in the prior studies, was using this definition, and we identified women who had infertility without infertility treatment. We identified 19,000 women with endometriosis and over 700,000 women without endometriosis. Those with endometriosis were older, like the mean age was 33 years, compared to non-endometriosis, 30 years. Income quantile, we also saw a difference in those without endometriosis were more in the lower income quantiles. That's important for you, I haven't mentioned, but in these large databases, we use the standardized difference instead of p-values to evaluate the difference between groups, and standardized differences more than 1.10 suggests a meaningful clinical difference. So we see that for age here, the standardized difference is more than 0.1, and also for this income quantile group. These are prior health characteristics, and as you can see, fibroids are very common in patients with endometriosis. 9% of them had fibroids also in the study databases that we used, compared to 2% in patients without endometriosis. This was also significant. So this is the association between endometriosis, no endometriosis with the adverse outcomes. We saw a higher risk for hypertensive disorders of pregnancy, preterm birth, early preterm birth, C-section. But what calls our attention is mostly that they had all these placental disorders. The risk was higher. It was higher for placenta previa, placental abruption, and other placental disorders. Stillbirth was also more common in patients with endometriosis. So we wanted to know what is the role of fertility treatment. And in this case, fertility treatment is considered a mediator, because some patients with endometriosis will have fertility treatment, and we wanted to know what proportion was through that fertility treatment or the endometriosis itself. So in this mediation analysis here, I want you to focus on this 4 column, where you will see the endometriosis direct effect. So as you can see, we are accounting for the effect of fertility treatment. And as you can see, endometriosis had, in most instances, an association with each of the adverse outcomes. In the last column here, we didn't see a mediation by the infertility without fertility treatment or the fertility treatments. So this suggests that maybe it's more the endometriosis itself. Here is for all the placental disorders that we saw. You can see the direct effect of endometriosis as high as 1.82 for those with infertility without fertility treatment, 270 for those with IVF, but mediated through the endometriosis direct. So this endometriosis direct effect. The proportion mediated by the fertility treatments is very low, except for stillbirth, where we saw that ovulation induction and IUI mediated 21% of the association between endometriosis and stillbirth, and IVF for ICSI mediated 41% of the association. So we concluded with this work that endometriosis, independent of fertility treatment, might affect placentation and result in adverse pregnancy outcome in this population. So that's what I had to present in terms of those initial studies. More recently, we were interested in third-party reproduction. So patients who are gestational carriers, also known as surrogate. So we know that surrogacy or gestational carriage is increasing. These patients are going to carry a pregnancy and have a pregnancy and delivery for individuals or couples that are not able to carry a pregnancy, either for medical conditions or male sex couple individuals. But there are other conditions like social surrogacy, for example, that we are also seeing is increasing. Through gestational carriage, we see is a patient who is going to receive an embryo using gametes that are from the intended parents or sometimes through donation. In Canada, the Assisted Human Reproduction Act will kind of guide the use of gestational carriage in Canada, but unfortunately, we don't have like clear indications. They only say in the Assisted Human Reproduction Act that a gestational carriage cannot be paid for the service that she is providing, but the intended parents can provide out of like pocket expenses only. And the only indication clinical that we have is that they should be older than 21 years. In Canada, we see about 900 arrangements per year. It decreases during COVID, but we are seeing now that we are going back to prior numbers. The American Society of Reproductive Medicine has these guidelines for gestational carriers, where they say that preferably they should be between 21 and 41 years. Ideally, they should have had a prior pregnancy uncomplicated, and we can accept but no more than 5 pregnancies and no more than 3 C-sections. And the gestational carriers must have a stable family environment. That's the guidance that we have. Then in JAMA, they published in 2023 this study where they are showing how the trends in gestational carriage are increasing in the US. So about 4% of all the IVF cycles were for gestational carriers between 2014 to 2020. And they are seeing an increase from 2.7% in 2014 for IVF cycles were for gestational carriers compared to 5.2% in 2019. Here are the characteristics of the gestational carriers and the cycles with gestational carriers versus no gestational carriers. And you can see here that 51% of those gestational carriers used donor oocytes, and those without gestational carriers, 11.3. The number of embryos transfer is also important here we see that those with gestational carrier had, they say, if we combine 2 and 3, is gonna be lower than the no gestational carrier. The ages, only 7.2% were older than 40. And when they studied the outcomes, they were interested in preterm birth mainly. And for preterm birth, they showed that gestational carriers had even a lower risk of preterm birth compared to non-gestational carriers. For multiple pregnancies, they had more multiple pregnancies compared to non-gestational carriers. So this was reassuring, and we wanted to know if the same is happening using ICS data here in Canada. So we published our study last year in September. The use of gestational carriage is increasing, but we don't know what is the risk of maternal morbidity in this group of population, and we wanted to know more about neonatal morbidity. So we wanted to know the risk of SMM and SNM. So severe maternal morbidity and SNM, these are surveillance indicators that are now more commonly used to study maternal and offspring outcomes. So we conducted this population-based study using ICS data from 2012 to 2021. The exposures were gestational carriers, and we compared them to like unassisted conception and with in vitro fertilization. That was the comparison too. The main outcomes were SMM and SNM. As secondary outcomes, we studied hypertensive disorders of pregnancy, C-section, preterm birth, and postpartum hemorrhage. So for this, we submitted the paper to the journal doing like a usual type of analysis, adjusting for confounders. And they say, okay, we are interested in the paper, but we want you to do propensity score analysis and try to have a more homogeneous population. So we did propensity score based overlap weights to create cohorts that were balanced across baseline characteristics. And we used multivariable logistic regression to do this propensity score. Then we used modified regression models to evaluate the weighted relative risks. And again, we also accounted for more than one birth in a woman during the study period. And a gestational carrier could have had it, she by definition would have had a child prior, not through gestational carriers, and then one through gestational carriers. So all that correlation was studied through the propensity score analysis and modified Poisson regression. So this is like the population that we were able to identify. So over 800,000 women without unassisted conception, 16,000 with infertility, with in vitro fertilization, and 806 gestational carriers. This is the characteristics of the population before the propensity score was applied. So as you can see, gestational carriers were all there here, 33.4 years, compared to the unassisted conception group, but they were younger compared to the IVF group. Gestational carriers, we combined 1 and 2, were more in, as you can see by the standardized difference, compared with the IVF group. They were in the lowest income quantile groups. Gestational carriers were also different in terms of parity. They were mostly multiparous because to be eligible to be a gestational carrier, ideally you should have had a prior pregnancy, but in this population, 9% did not have a prior pregnancy. Gestational carriers were also more obese compared to the unassisted conception and IVF group, and also they were more likely to have chronic hypertension. Then we applied the propensity score and overlap weighting. As you can see here, these are the standardized difference. So they are all all of them 0. So we can see after applying the propensity score that our groups were very similar. These are the outcomes. So for SMM, severe maternal morbidity, is an outcome of 42 composites that indicate very severe conditions during pregnancy and delivery that can be very close to death in the mom. And in the SMM was 2.3% in women with an assisted conception, and it was 3 times that in the gestational carriage group, 7.8%. The weighted relative risk was 3.30. For hypertensive disorders of pregnancy, you can see also that the rates are higher. The same for preterm birth. It was 6% in an assisted conception compared to 11% in gestational carriers. Postpartum hemorrhage was very high. While it was 5.6% in an assisted conception group, it was almost 15% on patient in gestational carriers. This is when we compare gestational carriers with IVF, because some will say, oh, maybe the complications that gestational carriers are having is because they are having IVF. So we wanted to compare with them, and also in that comparison group, we saw that SMM was higher in gestational carriers. It was 4.3% in patients with IVF compared to almost 8% in gestational carriers. And the same for hypertensive disorders, preterm birth, and postpartum hemorrhage. We found an association. So we conclude with this work that among singleton births, gestational carriers has a higher associated risk for severe maternal morbidity, hypertensive disorders of pregnancy, and postpartum hemorrhage. Compared with both groups, those who conceived without assistance or those who had IVF. Gestational carriage was associated with preterm birth, but fortunately there was less clear evidence of a higher risk of neonatal morbidity in the children. So given the increased use of gestational carriage these days and the potential risk of severe maternal morbidity in this group and adverse outcomes, we are advocating for a strict or judicious selection of carriers and more guidance and policy about what should be the eligibility of these patients. And we also need to understand why is this happening. Is it because they are receiving an embryo that they have not been exposed before, or what could be other reasons for this high risk? So in conclusion, today, I wanted to talk to you about link administrative health data to show how powerful this data is, and in my case, to study infertility, assisted reproductive technology, and pregnancy outcomes at a population-based level, and that we should separate the effects of underlying infertility from those of the fertility treatment. Confounding by indications is central methodological challenge in this field, and findings across this study demonstrate that both the infertility diagnosis itself, but also the modalities could contribute to different adverse obstetrical and neonatal risk. And we should interpret cautiously the observational data. So I wanted to acknowledge Queen's University, my prior institution where I was able to build this research program, the Department of Obstetrics and Gynecology, CIHR for funding my research, ICS for all the support, and now the institute, my new institution. Thank you everybody for being here today, and those on Zoom, and I'm happy to answer questions.
There is one comment on Zoom from Sasha Bernatsky to you. Ben, there are many researchers linking in MIN data sets for pregnancy outcome research in Quebec, including Isabelle Malhamé and Evelyn Vinet at CORE.
Yes. Yes, I know good. Yes.
Any questions in the room?
So great talk. Thank you so much. I learned a lot. So early on, you mentioned this issue of confounding and approaches to try to address it. One that you didn't mention, I'm sure with good reason, was sort of randomization. When these fertility interventions were, I guess, coming online or being demonstrated to be effective, like, were there not large randomized trials to establish or explore, adverse events and so on? I guess not.
So I guess more like the randomized control trials that we have more are mostly to know like if what type of treatment will increase pregnancy rates. Pregnancy rates after IVF. What is going to result in a higher pregnancy, in a higher successful treatment. Some will be powered to investigate pregnancy outcomes, but not many of them. So I think now we should move more, not only to what is the success rate of this treatment, but we need to account in successful definition, what is the health of the mom during that pregnancy and what is the health of the child at birth and after.
And a follow-up question, more sort of epi focus. So I was reading recently about like left censorship, right censorship, immortal time bias, those sorts of things. So to get in this type of administrative database, to enter, to be detected within it, if you're receiving assisted fertility, I imagine that gets captured pretty early on in the course of pregnancy, even prenatally, whereas the unassisted reproduction, is it possible that you're missing people who are, attempting to become pregnant and either having early sort of miscarriages or stillbirths? Like, is there sort of an immortal time to being in the assisted fertility group versus, in the unassisted versus assisted?
So in Born, the pregnancy database that we use in Ontario, pregnancies are registered if they are more than 20 weeks. So you are right that those that are lost like earlier, before 20 weeks, are not going to be included in this database. IVF pregnancies or fertility treatment pregnancies are also more likely to be associated with early losses and miscarriages. So I don't think we are missing, we are also missing those. So I think probably we are missing both groups the same, but that's a limitation that we are.
So in both, or in each group, you had to get to 20 weeks?
Yes.
Okay, so you're kind of
exactly in both groups. Okay. Yes.
Thanks.
Yes. Nina.
Great talk, Maria. So I'm just wondering, you're showing that there are adverse neonatal outcomes in these children. Do we know if some of these, there's suggestion that there are, right? Do we know, because I saw that in the list, there was also the EDI. So we get to see how the early child is developing. So do we know from this data set whether, for example, early outcomes in terms of neonatal outcomes, whether it actually leads to, I don't know, deficits, delays in these children, maybe around 3, 4, or 5 when they're preschoolers?
So the EDI, we have not used it and hasn't been used, and I hope to use it in the future. We are working on that. We have done some work on ADHD and ASD. I didn't present that because of the time, but something to do in the future. But we have done ADHD and ASD, so neurodevelopmental.
I'm aware,
autism.
That's why I'm mentioning it.
So attention deficit and hyperactive disorders and autism.
Yeah. So there is an association, right?
We have those papers I can share with you. So we find that even in the infertility group, without fertility treatment, we see an association. It increases a little bit with the treatment, but when you compare fertility treatment against the infertility without treatment group, then we don't see the association anymore. So our hypothesis is that it might be the underlying infertility diagnosis.
Can you remind me the age group that you ran those studies, by the way? Like what age were the children with the ADHD and the ASD group?
We were able, because we follow them, we create
Yes.
like prospective cohorts with these databases, and we were able to follow the children, I think, for more than 8 years.
Yeah.
So yeah,
I want to work with you on
Yeah.
the EDI.
good. Yes, we will do that. Yeah.
Thank you very much,
Thanks.
Maria.
Thank you.
Great, thanks. Oh, one last online question.
Dr. Bernaski, do you want to ask your question or do you want me to read it out for you?
I can you hear me okay?
Yes, we can.
Oh, no, I just enjoyed the talk, and I'm sorry I'm not there in person. I really liked your talk. But I'm not sure I understood the mediation analyses, and I'm wondering if you could just explain how you came up with the percent of proportion mediated.
So we did, I don't remember the exact name, but we did counterfactual, I think, mediation analysis. And I can send you, I don't know if we can go. But so using that method, do you remember the name of the authors? So for the, no, it's not there, but so using the method for this mediation analysis, we are able to identify why proportion is mediated by the disease, endometriosis in this case, or the fertility treatment. But I can send you the exact.
Oh, it's okay. Well, I'll look it up again. Thank you. I enjoyed your presentation.
Thank you.
Any other questions in the room? Any questions from Zoom? Last chance.
Thank
Thank you so much.
Thanks.